You send me the YouTube link also, please.
Ma'am, please start.
Yeah. So now we are going to start today's short topic discussion is on inflammatory bowel disease. Okay, so just wait, let me see. Audio and video all correct, everybody? Yes. Okay. So if everything is correct, let's quickly start with the difference. So today's topic is very simple. That is, this is one of the questions that come to you in your exam. You have to differentiate between the ulcerative colitis and the Crohn's disease. Okay. So please remember this, everybody, that these are the ulcero-inflammatory lesions of the intestine. So these are what they are ulcero-inflammatory lesions. इसका क्या मतलब होता है? What do you understand by these terms? Okay. So, you know, there are some diseases in our intestine which typically produces ulcers. So they differ in the type of the ulcers and in the nature, in the way the body behaves. Okay. So these lesions are called ulcero-inflammatory lesions of the intestine. Okay. So in these two predominant lesions that we have is ulcerative colitis and Crohn's disease. So that's the basic two important things that you have to understand. Okay. So if you're going to differentiate these two entities, you should be very clear that what is the difference between both of them. So we have to go in deep into the story from where it all started. Okay. So the story of inflammatory bowel diseases started from a very simple thing, simple code called as die. Okay. So you will die like that. Okay. So die. So it started from number one, dysbiosis. Number two, immune disorders or dysregulation. And number three, epithelial injury. Number three, epithelial injury. So there are three key things which are occurring in these. If you understand these three, it's a very easy topic to understand. So what do you understand by the term dysbiosis? Please remember, there are a lot of bacteria which normally reside in our intestine. So whenever they are altered, this is what is called as dysbiosis. So alteration of the normal intestinal bacteria is basically dysbiosis. So there's a very simple theory that a lot of bacteria are there which maintain. So it's like when you are you know, when do you don't get sad? When you're studying, you don't get depressed, you don't get sad because you're busy with something. Okay, but it's when as a medical somebody takes away your books, you start feeling sad. Oh, I'm not studying today, I'm not doing anything today. Just like that, intestine also happens the same thing. So till the time there are bacteria in the intestine is very happy fighting with them. But as soon as you remove the bacteria from the intestine, how do you remove? There is a very popular hypothesis which is called as hygiene hypothesis. Okay, so what is this hygiene hypothesis? So, you know, in India, when we stay in India, we keep on eating, you know, lot of bad foods. Okay, 𝗏𝗃𝗃s and all that bad foods. So these bad foods give us a lot of bacteria, and that is why our intestine is fighting with giardia, amoeba, and all those. But what happens in the West? There is everything is a canned food. Okay, so canned foods are there. Okay, so you have removed all the bacteria from your food. So what is going to happen is you're going to give a very hygienic food to your intestine. So there are no bacteria now. So what happens because of this? One, there are preservatives, okay, in this canned foods. So these preservatives themselves can cause epithelial injury. That can happen. Or the second thing that is going to happen is that there are no bacteria. So no bacteria means nothing. So your intestine doesn't have any work to do. So it is going to activate your immune system to fight against unknown pathogens. So it will start searching for some antigens against which it can fight. And also it will lead to the growth of pathogenic bacteria. So there will be pathogenic bacteria that will start coming when your good bacteria are not there. Okay. So all this was given by a theory called hygiene hypothesis. And that is why the incidence of inflammatory bowel disease is more in West as compared to the India. Because still we have a lot of amoeba and giardia sitting in our country. Okay. Now, coming to the second thing is immune dysregulation. So immune dysregulation is the key event which occurs in the inflammatory bowel diseases. Okay, so how does that happen? So these define what type of disease is going to develop. So let's understand the basics here. So I'm going to divide it into two types. Okay, so here what happens is, so let's look at these two diseases. One is called as Crohn's, okay, and the other is called as ulcerative colitis. So what is the difference in the immune mechanism in both of them? Let's understand this first. Okay, so the first difference that occurs in Crohn's disease is that there is a defect in the autophagy genes. Okay, so there is a defect in the autophagy genes. So autophagy genes are defective. So what happens is, due to any cause, NOD2 genes, okay, so one, autophagy genes are defective, like 𝗤𝗕𝗃𝗲𝗏, or your innate immunity is defective, So NOD2 is
Recording in progress.
okay. Okay, right. Okay. So, hi Aditya, hi Vanindra. Sorry, there was some loss of connection. So let's look at that. So now there are defects in the genes. So either the autophagy gene is defective or there is an innate immunity defect. So autophagy gene like 𝗤𝗃𝗃 and 1 is defective. So cell is not able to kill the pathogenic bacteria, and innate immunity is defective. So cell will start recognizing its own self antigen as a pathogenic antigen. Okay, so that is what is going to happen here. So please remember here that when I say that what is the pathogenic bacteria which affects the Crohn disease, so remember this is very important. This is called Saccharomyces. Okay, Saccharomyces cerevisiae. So that's the bacteria which is postulated to be affected in Crohn's disease, and that is why, so when this is a defective bacteria, so probably it's not killed properly by autophagy because there is a defect in the autophagy gene, or your innate immunity is defective, so cell starts recognizing the self antigens and it starts attacking. Okay, so that is why the antibody which is present in Crohn's disease is called as anti-Saccharomyces cerevisiae antibody. What is this called as? Anti-Saccharomyces cerevisiae antibody. Okay, so remember this organism very well. Now remember please guys that when we talk about Crohn's, one is the genes which we have studied. Apart from that, remember that whenever this pathogen enters into the body, always what happens is any pathogen which enters or any self antigen which is there, okay, which exact antigen we still do not know, this is recognized by the dendritic cells. Who recognize them? Antigen presenting cells. So dendritic cells recognize them and they go and present it to T helper 1 cells. So the main T cells here is T helper 1 cells. So it goes and gives the antigen to T helper 1 cells. So these T helper 1 cells, immediately release interferon gamma. And this interferon gamma will change the macrophages into epithelioid cells. Okay. And these epithelioid cells will form a granuloma. So this will form a non-caseating epithelioid cell granuloma. Non-caseating epithelioid cell granuloma will be formed here. Okay, non-caseating epithelioid cell granuloma will be formed here. So what happens is that granuloma is formed in Crohn's disease, and this is the hallmark of Crohn's disease. This is the hallmark of Crohn's disease. 35% of Crohn's disease patient will show you granuloma. 35% of the Crohn's disease patient will show you granuloma. So if we look at the pathogenesis of Crohn's disease, everybody should be clear that the main culprit here is T helper 1 cells, and the main interleukin or cytokine here is interferon gamma, and the main event that occurs here is non-caseating epithelioid cell granuloma. That's the hallmark of Crohn's disease. Okay, please remember, apart from this, you have to remember that the macrophages are also activated. Okay, so macrophages are also antigen presenting cells, so they will also recognize the antigen and they will release tumor necrosis factor and they will release interleukin 12. So interleukin 12 will go and activate T helper 1 cells, and in TNF will cause epithelial injury. So it will cause epithelial injury. So I told you the triad of inflammatory bowel disease is DIE. What is the triad which I told you? DIE. One is dysbiosis, that there is altered flora of the intestine. So I told you what is the altered flora here. So Saccharomyces cerevisiae grows. Okay. Second is immune mechanism. So immune mechanism you've just now studied here. That what happened, which immune mechanism is defective here? Obviously autophagy and innate immunity is defective here. Okay, and which T cells are involved here? Th1 cells. And what is the hallmark? Non-caseating epithelioid cell granuloma. That's the hallmark here. So that's the classical features of the Crohn's disease. Okay, now let's come to the ulcerative colitis. What is the difference feature here? So if we look at the ulcerative colitis pathogenesis, everybody should remember this, that in ulcerative colitis also the DIE works. So one is dysbiosis. The second is immune. So in immune that you have to remember here is, what do you have to remember in immune in ulcerative colitis? Here again some pathogen comes. We do not know what is the pathogen. Okay, we do not know what is the pathogen. But they have found that the antibody which is found in this case is Pianka. What is the antibody that is found in this case? It is Pianka. And whatever is the pathogen, this pathogen is picked up by the dendritic cells again. Okay, dendritic cells again, which are the antigen presenting cells. These dendritic cells will go and activate here Th2 cells. So this is the difference from Crohn's disease. So here 𝗤𝗃𝗃2 cells are getting activated. So these 𝗤𝗃𝗃2 cells will release interleukin 4, interleukin 5, and interleukin 13. So which will cause mucus production, Not only that, here also the macrophages will be activated, and macrophages will release TNF, which will cause epithelial injury, which will cause epithelial damage. So please remember, here the T cells that you are seeing is 𝗤𝗃𝗃2 cells. That is what you have to remember very clearly. So can I say, so if I have to draw a chart here, so let's quickly draw a chart and see here. So if I have to draw a table here, differentiating between the immune mechanisms of, first is the pathogenesis, right? Between the Crohn's disease and the ulcerative colitis. What have you studied here in the immune mechanism? So in the Crohn's disease, the main T cells which are involved are 𝗤𝗃𝗃1 cells. Okay, so main T cells which are involved here are 𝗤𝗃𝗃1 cells. Whereas in ulcerative colitis, the main cells which are involved are 𝗤𝗃𝗃2 cells. Okay. Second, you have seen the cytokines. Okay, so the cytokines which are released here are interferon gamma. Okay, so the cytokine which is released here is interferon gamma. That is what you have seen here. Apart from that, you have seen here that in cases of ulcerative colitis, we have interleukin 4, interleukin 5, and interleukin 13. Third thing you have studied is that the autophagy genes are defective. Autophagy genes are defective in Crohn's disease. Okay, so autophagy like ATG16L1, ATG16L1 is defective here. Apart from that, you have seen NOD-like receptors. Okay, NOD-like receptors are defective in Crohn's disease. NOD-like receptors are also defective. So there is a mutation in NOD2. Okay, so NOD2 is also defective here. So that is the main difference which is in the immune mechanisms of the Crohn's and ulcerative colitis. So first you have to understand this difference. Okay. Now once we are clear with this difference in the immune, let's come to the morphology. Okay, so let's come to the morphology. So to understand the morphology, let me draw simply. Let's draw like this. Okay, let's draw the intestine and see how it happens. Okay, so whenever I'm drawing the intestine, remember the most common site. Okay, so the most common site which is involved in Crohn's disease is ileum, closely followed by 𝗍𝗄𝐴𝐿 junction. Okay, so this is the commonest site which is involved by the Crohn's disease. Okay, so ileum is the most common site, followed by the 𝗍𝗄𝐴𝐿 junction. Whereas in ulcerative colitis, when I'm saying, so ulcerative colitis usually involves the rectum, or it can involve whole of the colon. Okay, it can cause pancolitis, and sometimes in reverse it can involve the ileum also. And this ileum, if it is involved in ulcerative colitis, it is called as backwash ileitis. What is this called as? Backwash ileitis. So remember, majority of the time it involves rectum, or it can involve whole of the colon, and that is called as pancolitis. Okay, so what is that called as? Pancolitis. And then it can involve ileum, which is called as backwash ileitis. So this is the clear difference between ulcerative colitis and Crohn's on the gross. So somebody says, what is a gross difference? First is the site difference. Okay, so in Crohn's disease, the most common site involved is ileum, followed by the 𝗍𝗄𝐴𝐿 junction. Whereas in ulcerative colitis, it usually causes pancolitis, and it can involve the ileum, and this ileum is called as backwash ileitis. Backwash ileitis. So that's about the site difference, gross difference that you have to see. Now, let's look at both of them are the ulcerative lesions of the intestine. So there has to be an ulcer, right? So how does the ulcer starts? So Crohn's disease mein the ulcer starts as an 𝗤𝗃𝗃 ulcer. Okay, so just a flat ulcer, 𝗤𝗃𝗃 ulcer. Okay, so 𝗤𝗃𝗃 ulcer is like जैसे कि आपके मुंह में छाला पड़ जाता है वैसा 𝗤𝗃𝗃 ulcer start होता है. धीरे धीरे it grows into 𝗘𝗊𝗺𝗃𝗃 ulcer. It grows into 𝗘𝗊𝗺𝗃𝗃 ulcer, like a snake. Then it grows into 𝗘𝗊𝗺𝗃𝗃 ulcers. These 𝗘𝗊𝗺𝗃𝗃 ulcers are going to grow deep. these 𝗘𝗵𝗃 ulcers are going to go very deep. Okay, so they are going to grow very, very deep. And when they grow deep, okay, so they're going to grow deep. So these 𝗘𝗵𝗃 ulcers are deep ulcers. So they can grow full throughout the epithelial layer, so throughout the intestinal layer. So if I look at the layers of the intestine, you all know what are the 4 layers of the intestine. We have mucosa, submucosa, muscularis, and the serosa. So remember, in cases of Crohn's disease, all the layer of the intestine are involved. It is full thickness involvement. All the layers of the intestine are involved. Okay, so full thickness involvement is there. So there is an ulcer in the mucosa. You can see the ulcers in the mucosa. So what happens is the areas which are not involved, okay, the areas which are not involved are normal. Okay, so the areas which are not involved are normal like this, and the areas which are ulcerated have burrows. They have gone down. So this appearance is very classically called as, I'll show you the image also. This is very classically called as cobblestone appearance. What is this appearance called as? Cobblestone appearance. So normal epithelium ऊपर होता है, ulcers नीचे चले जाते हैं. Okay, so normal deep. So this looks like the cobblestone, okay, pavement. We will just see now how does it appear. So that is how it appears. So that is cobblestone appearance, which is looking like in the mucosa. Now, in the submucosa, what I'm going to see is there are granulomas. Okay, so there are granulomas. So there are granulomas. So that is why the submucosa is widened. Submucosa is widened. There are non-caseating granulomas which are present in the submucosa. Now, because there are granulomas which are developing in the submucosa, obviously the fibrosis is going to occur. So granulomas have a layer of non-caseating epithelioid cell granuloma, and then there are fibrosis. So fibrosis ho raha hai, thickening ho rahi hai. So the mucosa gets thickened. Mucosa gets thickened and fibrosed. Okay, so there is fibrosis and thickening in the mucosa. Obviously, when there is so full thickness changes which is occurring, what happens is that in the serosa, the fat from the surrounding starts creeping. So this is what is called as creeping fat. Okay, so we can have creeping fat. So we can have mucosa, which shows you ulcer. With these ulcers could be 𝗘𝗵𝗃 ulcers, starting from 𝗪𝗱 ulcers to 𝗘𝗵𝗃 ulcers and leading to cobblestone appearance. Some mucosa will show you granuloma and widening. Muscularis will be thickened and show fibrosis, and serosa will show creeping fat. Please remember, a very important thing here that you have to remember is because of this all changes which is occurring here. Okay, so these all changes which is occurring here. Obviously, there is fibrosis and thickening of the muscularis. So because of that, the narrowing of the lumen occurs in the Crohn's disease. So narrowing of the lumen occurs. Isiliye, on radiology, you see a very typical sign here, which is called as string sign. कौन सा sign बोलते हैं इसको? String sign. That you remember as string sign. Okay, which we will see in radiology also. So you can simply remember it. Very simple way to remember Crohn's disease is CSF. We have just now seen that Crohn's disease starts with C. So it has cobblestone appearance. It has cobblestone appearance. Okay. Of course, there is thickening, okay, of the muscularis. So there is stricture formation. And because the ulcers can go deep, so there are fistulas which can be formed. There are fistulas which can be formed. Also, what did you see? That because of the ulcers, deep ulcers, there is usually creeping fat which is present in the serosa, which is seen in the outside. Okay. Also, you saw because of the strictures, we can have string sign which can be seen in the radiology. Okay, right? Then apart from fistula, we can have fissures also, which we can see. We can see fissures also. So we have strictures, we have fistulas, we have fissures, we have cobblestoning. So all these are very characteristic features of Crohn's disease that you all have to remember. Okay, so that is about morphology that we have to remember. Now, once we are clear with this, so are you clear with the gross in the microscopy table that you have to draw? For now, gross में क्या लिखोगे Crohn's disease में? So usually the site first, the ileum and the ileocecal junction. Ileum followed by ileocecal junction. Second, ulcers can be seen. These are 𝗪𝗱 ulcers which can grow into 𝗘𝗵𝗃 ulcers. And third, in the gross, you can see strictures. Okay, strictures can be seen. Now microscopy, what will you see? You will draw these muscularis, submucosa, muscularis, and serosa, and you will write the 4 changes that I've just told you: ulcers, cobblestoning, granulomas, thick widening, thickening, fibrosis of the muscularis, and creeping fat. So that is very clear for the Crohn's disease. Now, in contrast to this, let's look at the ulcerative colitis now. So when I'm talking about ulcerative colitis, in contrast to the Crohn's disease, ulcerative colitis is a superficial disease. Okay, so usually it has broad-based ulcers. So in contrast to the 𝗍𝗕𝗃 ulcers, which you've seen in the 𝗍𝗕𝗃 ulcers with Crohn's, this ulcerative colitis has broad-based ulcers. Okay, so we have broad-based ulcers like this, which you can see. Now here you have to remember here, since you have just now seen that the most important cells that are activated here are T helper 2 cells. Please remember, T helper 2 cells releases interleukin 4, interleukin 5, interleukin 13. Apart from that, also recently they have found that Th17 is also activated in ulcerative colitis. So this Th17 basically activates interleukin 23 and interleukin 17. Which goes and activates neutrophils, So there is a lot of neutrophil collection which can be seen in ulcerative colitis, especially around in the crypts. Okay, so this, remember, this change is not unique to ulcerative colitis. It can occur in Crohn's also, but it occurs more common in ulcerative colitis. So what can happen is that whenever the crypts are filled with neutrophils, these are called as crypt abscesses. Because of which, now what will happen is the crypts, when they will start healing, they will be haphazardly branching. So you can see crypt branching. Okay, also. So please remember, everybody, whenever I'm talking about ulcerative colitis, there are a lot of neutrophils. Okay, so name itself says ulcerative colitis. Okay, so this ulcer, number of neutrophils hote hain. So this change usually indicate active disease. And remember, this can even occur in Crohn's. So whenever Crohn's is active, this also can show you these crypt abscesses. So they are not unique, but they are more commonly seen in ulcerative colitis. Okay. Now, apart from that, what happens is, so they are broad-based ulcers and they only involved mucosa and submucosa. So if we look at the layer, we have mucosa and submucosa which is involved. So the ulcers are superficial ulcers, broad-based ulcers, and the mucosa and the submucosa are only involved. Now, so if I'm talking about now microscopy, okay, of the ulcerative colitis and Crohn's, so can I write like this? Okay, so I'll write Crohn's only here. Okay, so I'll write Crohn's only here versus ulcerative colitis, so you don't confuse between them. So if you look at the mucosa, submucosa, muscularis, and serosa, please remember, in the muscularis, we just now studied that in Crohn's disease we have 𝗍𝗕𝗃 ulcers, which grows into serpiginous ulcers. ठीक है? Ulcerative colitis में क्या होता है? We have broad-based ulcers. ठीक है? Broad-based ulcers. Submucosa gets widened. Okay, so let's change the color and write. So it gets widened, and there is granuloma. So here nothing, no widening, no granulomas. Muscularis में thickening and fibrosis. इसमें तो involved ही नहीं होता. Serosa में we have creeping fat. Again, which is not there in ulcerative colitis. So are we clear with the basic difference here? So first, only mucosa and submucosa are involved in ulcerative colitis. Now, you know, a lot of our nerve plexus are present in the submucosa, जिसमें ganglion cells होते हैं. So sometimes whenever there is inflammation, so much as inflammation is going into mucosa and submucosa, these ganglion cells can damage. And whenever there is a damage to the ganglion cells, this leads to a change which occurs in ulcerative colitis, which is called as toxic megacolon. So why it is called toxic? Because it's because of a lot of inflammation. So there's a lot of inflammation that is causing toxicity, and because of that, the ganglion cells are damaged. So it becomes megacolon. It becomes dilated like 𝗪𝗪𝗪 disease. It becomes megacolon. It becomes dilated. So that is why it is called as toxic megacolon, which is very classical feature of ulcerative colitis. Okay. So now understand the difference between the Crohn's and ulcerative colitis, you have to remember the 4 layers in the microscopy and you have to differentiate. Okay? So that is about Crohn's and ulcerative colitis microscopy. So whenever you have writing in the exams, guys, what have you studied till now? How are you going to write? So you're going to write Crohn's. Just for the exam purpose, I'm telling you. Okay, so you have to write in 4 headings. First heading you have to write is immunology, basic pathogenesis में difference, immunology. Second, you write gross findings. Third, you write microscopy. And fourth and the last point that you have to write is complications. These are the 4 headings in which you should write this exam question. Okay, so immunology we have just discussed here. So Crohn's disease में क्या discuss किया? T helper, 1 cells and autophagy and innate immunity. इसमें T helper 2 cells. Okay. Gross में क्या study किया? Crohn's disease usually occurs in the ileum. Okay, followed by 𝗍𝗂𝗃𝗃𝗏 junction. Ulcerative colitis usually occurs in the rectum or it can cause pancolitis. Okay, pancolitis. Microscopy में क्या पढ़ा? All the 4 layers, mucosa, submucosa, muscularis and serosa are involved in Crohn's. In ulcerative colitis, only mucosa and submucosa are involved. Okay, and 4 is complications. So whenever we are going to study about the complications, you have to remember. So whenever we have to study complications, please remember what are the complications we have just studied for Crohn's. Remember, we have just now studied that this causes your stricture, your fistulas, okay, and also your intestine will become cobblestone appearance. Remember the CSF. And the most important, so there are chances of lymphomas, okay, because there are a lot of inflammation. So lymphomas chances and cancer chances are there. Okay, so lymphomas are more in cases of Crohn's disease versus carcinoma. Whereas whenever I'm talking about the complication in ulcerative colitis, remember here we have a very classical finding which is called pseudopolyps. So this is in contrast to the cobblestone which you see in Crohn's. What is the difference? So in cobblestones, what happens is there is a normal intestine ulcer, normal intestine ulcer, normal intestine ulcer. So it's like cobblestone. Pseudopolyp में क्या होता है कि whenever the ulcer is trying to regenerate, it regenerates like a polyp. So it doesn't have a fibrovascular growth. There's no a fibrovascular core नहीं होती है. There is only a proliferation of the epithelium which is there. Okay, so this is what is called a pseudopolyp, which you see in ulcerative colitis. And again, the chances of carcinoma are much more in ulcerative colitis, and it depends upon the duration, कितने सालों से ulcerative colitis है, and extent of involvement. So that is the chances of carcinoma in ulcerative colitis. Now, of course, if you have to add extra points, so serological marker, okay, diagnostic marker or serological marker. Sorry. So just now we had studied in the pathogenesis itself, okay, and the Saccharomyces cerevisiae antibodies are very classical for Crohn's, and P antibodies can be seen in ulcerative colitis. So is everybody clear with this? Yes, so everybody is clear with this. So this is your difference between the ulcerative colitis and Crohn's in a gist. That's a classical gist of Crohn's and ulcerative colitis. If you write these 5 points and you expand them, you're going to get full marks. Now I'm just going to show you some images so that you understand the basic differences which we have studied, and some images that you should know in inflammatory bowel diseases. Okay, let's look at them. Okay. Okay, guys, so can you see this image here? Okay, so this is what is called as a cobblestone appearance. Okay, so this is what is called as a cobblestone appearance. So can you see that there are ulcers here? Okay, so these are the ulcers which are there. Okay. Okay, so these are the ulcers which you can see, and normal intestine you can see here. So normal intestine ऐसे है और ulcers नीचे चले गए हैं. So this is what is called as cobblestone appearance. Okay, so all this is cobblestone appearance. So this has to be in contrast with the pseudopolyps which you see. Okay, so let's look at this pseudopolyps. So these are the pseudopolyps. Okay, so these are regenerating epithelium. So whenever there's a broad-based ulcers, there are a lot of regenerating of the epithelium which is starting, or regenerating of the epithelium appears like pseudopolyps. Okay, so pseudopolyps are seen in ulcerative colitis, which all of you should be very, very clear. Okay, one is that morphology. The second morphology that I want to show you is one more image here. Okay, look at this. So what happens is, can you see, because of the ulcers, this is what is serpiginous ulcer. So this is because of the ulcers, you can see this is the remaining mucosa here. So this is cobblestoning. And what do you see here is the lumen is narrowed. So this causes stenosis. So there is narrowing or stenosis of the terminal ileum in this case. And this is what causes strictures also later on. Fibrosis will also occur and it will cause strictures. And this causes string sign on the radiology. So if you look at the radiology, it is very classically string sign that you will see here. Now, remember again, just an image to show you cobblestone appearance, and there is strictures which you can see, and the wall is thickened. Muscle is, because muscles is thickened, you will see thickened wall in the cases of ulcerative colitis. So that has to be very, very clear to everybody. Okay. Now, once we are clear with this, everybody knows this. Now I'm going to show you another diagram. Please remember this diagram and never forget it. This is non-caseating granuloma. You can see these Langerhans giant cells, okay, and these are Langerhans giant cells, and the slipper-shaped nucleus which you see is epithelioid cells. So there are a lot of epithelioid cells, Langerhans giant cells, and the lymphocytes. So this is what is called as non-caseating granulomas, which everybody has to be very clear. It is very classical feature of Crohn's disease, and it is seen in at least 35% of the Crohn's disease. Okay. Okay. Now let's come to another thing that you have to see is this. This is what is 𝗍𝗱𝗃 ulcers, guys. So if it starts as a 𝗍𝗱𝗃 ulcer, remember these 𝗍𝗱𝗃 ulcers not only can occur in intestine, it can also occur in tongue, lip, palate, pharynx, anywhere. Okay. So these are 𝗍𝗱𝗃 ulcers which can be seen in Crohn's disease. Okay. So this is like your mouth chala which occurs, isn't it? Okay, one more diagram image I wanted to show you is a cryptabscess, which should be clear. What do you understand the term cryptabscess? Whenever there is a collection of neutrophil inside the crypt, that is cryptabscess, and it indicates active disease. It indicates active disease. Okay, so whenever we have active disease, any Crohn's or ulcerative colitis can show you cryptabscesses, but ulcerative colitis shows you more. Okay, so this is what is called as crypt abscesses, which you can see in your active inflammatory bowel diseases. So is everybody clear with this? Yes. So that is your difference between ulcerative colitis and inflammatory bowel disease. I hope everybody is clear with this. Yes. So if there are any doubts, please ask me now so that we can end this session. And to just take a gist, remember, it's a very easy way to remember. Differentiate the immunology, gross, microscopy, and the complications. So if you divide your question into 4 parts, and 5th is serology. So 5 parts, so you will get full marks in all of these. Remember, the patients usually present with the history of diarrhea, bleeding, abdominal pain. All these can be the history which you should be remembering. Okay, right. So yes, so if there are any doubts, please ask me now so that we can finish the session. Okay, Sonal, I've taken your point. We'll be starting YouTube revision sessions too soon. Yes, that's my agenda. I will be starting that soon. Yes. Yes. So, Medico, I don't know what is your name, but it is always good to study Robbins. So, as a teacher, we basically try to make images easy for you, the text and the concept easy for you, but it is always good to read Robbins. Reading textbook always helps. Every line has a meaning. So we always help you understanding the concept well, but yes, books cannot be substituted. It's good to read textbooks line by line. Yes, and we will always help you understand the concept better, and we can help in making you understand the points and what author wants to say behind the lines. So that's why teachers are there. Yeah. Anything else you have? Any doubt else that you want to ask? Okay. So if there are no doubts, we close this session, guys. Right? Okay.
Completing the NEET PG syllabus can be challenging. DocTutorials presents NEET PG 2025 Live Power Pack. Whether you are at home, college, hostel, or library, our live classes will be right on your screen. Simplify complex topics into easily understandable concepts and prepare all 19 subjects effortlessly with our expert guidance. Our NEET PG 2025 Live Power Pack offers live classes for complete coverage of all 19 subjects, 19 tests and discussions, full access to NEET PG Power Pack, quick revision program, recorded sessions for reference, hard copy workbook based classes, post-session tests, and grand tests and subject tests. Our eminent faculty. NEET PG 2025 Live Power Pack, bringing classrooms to your doorstep. Enroll now.